All right, welcome back, everybody. My name is Dr. Konkau, and today I am joined by a good friend, Dr. Jen Emberger. Welcome, Jen.
Thank you.
So we did residencies, different residency at East Carolina University, and she is a MedPeds or medicine pediatrics residency, and now she's an infectious disease attending at East Carolina University. Well, congrats, Jen.
Thank you.
All right, we'll be discussing about MedPeds and infectious disease. So briefly, tell me, your path and why you chose MedPeds in the beginning, and then maybe why you chose infectious disease.
Sure. So I think I'm a little bit unusual because I kind of knew what I wanted to do very early on.
Yeah.
So in college, I took a trip to Zambia and I was there for 2 months and I took a class on healthcare in developing countries. And then I did some HIV research and I worked with a Peds ID guy. And so I was like, oh, I think I want to do Peds ID because I like kids and infectious diseases seems interesting. And then I also learned about public health. And so I actually applied to a bunch of MD, MPH programs and did a combined med school. Combined is kind of like the theme of my career.
Yeah.
So I did 5 years MD, MPH, got my MPH in med school. And then I think it was my second year of med school. One of my friends was starting a MedPeds interest group. And I was like, ooh, what's MedPeds? And, she's like, it's, internal medicine and pediatrics, a combined residency, and you come out, able to practice both. And it's a little bit more training than just doing family medicine. And in both medicine and peds. And so I was like, oh, that sounds great. If I want to do global health, then I can really just treat anybody who walks into the door. So then I was like, I definitely want to do med peds. And I really still like infectious diseases, so I'll sort that out later. And so then I did residency. That was 4 years. And I actually initially started doing a combined fellowship of both adult ID and Peds ID. So I did 2 years of adult and 1 year of Peds. And then my current job opportunity actually became available. And I knew that I really wanted to go back to ECU just because I felt like I got such good training in residency and I liked the area. I just liked the people that I worked with. And so once that job came up, I decided to just focus on adult ID. And so then I got my current position. So my path is a little bit odd, I think, compared to other people's, but
Yeah, it's a very long path for sure.
Yes, I was a PGY7 last year, so.
But it really doesn't matter as long as you enjoy the whole path during your whole experience. And just briefly, if you can describe to the students the job, what do you do as an infectious disease besides COVID-19?
Yes. So I have an academic position. So I'm, associated or I'm officially an employee of East Carolina University. And so I really like it because I kind of wear a lot of different hats. So like last week, I was on the inpatient service. So other teams can call me. So surgical teams, medicine teams, all sorts of teams can call me for questions, that they need help with for infectious disease questions. So that's sort of like the inpatient side. And then this week I'm not on service. So today I had my HIV continuity clinic. On Wednesday, I'll have my general ID clinic and just see patients either as hospital follow-ups or patients in the community that are referred to me with infectious disease problems. And then on top of all that, I actually worked it into my contract that I can do global health. So I was supposed to be in Africa this summer, but COVID kind of messed that up. So next summer, hopefully I'll be going to Eswatini and working on developing a rotation for medical students and residents to participate in and kind of get global health exposure. And then with the rest of the time that I have left, I do a little bit of research, which, isn't required, but I kind of like some clinical research because I think it's just applicable and kind of fun to be involved with. And then I also do some teaching of our fellows. So, we give didactic lectures and we also do board review. So I kind of get to wear a lot of different hats, which for some people, they may not like that, but I love to do a bunch of different things because I think it keeps it interesting. So any one day is never the same. And I think that's what's kind of fun and exciting. So.
Okay, awesome. probably a lot busier with COVID than
Yes.
normal run years in infectious disease.
Yes.
Uh,
Yeah, when the pandemic first started, I was in fellowship
mhm,
and we were having twice daily meetings, just about COVID patients. And we were involved, we were one of the clinical trial sites for remdesivir. So
mhm.
we had to like meet with Gilead every day to talk about that. And then, talk about the patients that were on our service and what kind of treatments we were using that may or may not work. And so, yeah, kind of interesting times.
Awesome, awesome. And now, this interview is two separate, MedPeds and infectious
Mhm.
disease. I know you probably said that you decided that you want to do like a broad range
Mhm.
medicine. Um, you discussed regarding family medicine and MedPeds. They have
Mhm.
overlapping, I guess, practices. What made you decide on MedPeds versus family medicine, or just the two different other primary care services?
Yeah, so it's kind of twofold.
Mhm,
So family medicine is a 3-year residency program.
mhm,
MedPeds is 4 years. So MedPeds kind of breaks down to roughly 2 years of peds and 2 years of medicine in
mhm.
terms of all your training.
Yeah.
So you get a little bit more pediatrics. Last that I checked, I think for family medicine, you get maybe like half a year dedicated to pediatrics. So I knew I wanted to have more exposure to that. And then family medicine, you do OB-GYN and you also do surgery as part of your rotations, but you don't do that for MedPeds. And I'm not really a procedure person. I mean, I did them in residency to be proficient and, to become a good doctor. But that's not really my jam. And so, for me, that was something about family medicine residency program that wasn't really that much of interest to me. And then, so one of it was just sort of the composition of the residency training. The other thing is that for fellowships, family medicine has a smaller list of fellowships that are available afterwards. And so since I knew I wanted to do ID, you can't really do family medicine and ID. And so if you truly wanted to do primary care, then your options would be to do either family med or MedPeds. But if you wanted to do a fellowship, there's somewhat more limited options from the family medicine route. So
Understood. I think you hit the nail on the head there. There's a very, you can probably do any fellowship you want with the MedPeds.
you
Uh,
can.
yeah, yeah. All right. Thank you for that.
Mhm.
And so, what made you? You had decided on infectious disease from an earlier standpoint. Um,
Mhm.
what what drove you to do infectious disease versus any other subspecialties?
hmm So for me, I just think ID is so interesting. Like it's such a cool field. There's such a wide range of infections, from viruses and bacteria and fungal infections. And, you see a lot of weird stuff in the United States, but you see weird stuff outside the United States. So I just liked the breadth of, subject matter.
Mhm.
And I also like that it's not confined to one system, so like when I, have to go see a patient, I have to take into account all their systems. Like I'm not just focusing on the kidney or the lungs or the heart, I kind of take everything in whole. And so for me, I love that aspect of it.
Mhm.
And I also just like that it's such a changing field. I mean, who would have thought we have this novel coronavirus this year,
Yeah, yeah.
And it's not the first time that we've had new bugs. I think the cool thing is that we have new bugs that we learn about, and then we have old bugs that we learn new things about in ID.
Yeah.
So for me, it was just, I just think it's such a fascinating field, and I just love it.
Awesome, awesome. And then for from like a student's perspective, what do
Mhm.
you think are like the personal qualities of a successful infectious disease physician?
So I think being detail oriented,
Hmm.
if you meet most ID doctors, we're
Yep.
all about the devils in the details. And so oftentimes we get called for very like nebulous consults, like this patient has fevers, why? Or,
Yeah.
they have a white count. What could be the reason for their white count? Or, they have HIV and their CD4 counts in the toilet. What are all the possible infections they could have?
Yeah.
So I think that being detail oriented is definitely definitely one of the key qualities and kind of what people look to ID doctors to provide. One of my old attendings say, we don't do procedures, but what ID doctors bring to the table is a brain. And so we just bring a brain and being able to focus on details. So I think that's pretty a good quality to have. And then just being curious, the field is always changing. There's always updates. There's, new guidelines, new data always coming out. So I think just being able to kind of be curious and always, kind of look up what's out there is another really good quality to have in an ID doctor.
Awesome. I know you touch upon the academic aspect. Is there a lot of changes if you're infectious disease in a community private practice, especially with the schedule and work-life balance and things like that?
Yeah, so there's a wide breadth of what you can do. So with private practice, it's definitely higher volume, I would say, because you're usually in practice with a couple other partners, and you have to make money, and so I think some of that is you just have to see a lot of patients every single day. And not that we don't see a lot of patients in an academic center, but it's sort of it's, I guess, less of a business than being in private practice. But the flip side is you also have a lot more flexibility. So I have a number of friends who've gone in private practice, and, they're able to, if they want to close the clinic, they can close the clinic for whatever period of time, or, or if they want to take vacation or, do something international, there's kind of less red tape because you're somewhat your own boss. But I think overall, no matter whether you do private practice or you do academic ID, I think in general, the quality of life is good. And there's a good work-life balance. We're not doing procedures. There's hardly ever an emergency in the middle of the night that an ID doctor has to get called in for. I always tell my fellows that unless the patient has malaria or Ebola, we ain't coming in. And I mean, it's kind of tongue in cheek, but it's true. Like most of the time you're able to at least give people, empiric antibiotic recommendations over the phone, or kind of help, to guide them. And so there's not really, I feel like that makes for like a good work-life balance. You don't have to actually do any in-house call as an ID doctor. So that's pretty nice. And if you do private practice, if you're not contracted with a hospital, then you may not have to do any inpatient. And so then you may not have any weekend call or any overnight call. So it's sort of, the world's kind of your oyster in terms of what you want to do with ID, but you can definitely find a great balance and have plenty of time to do what you want.
Awesome. Thank you for that. So, you seem super interested in ID. What do you think is like the most exciting aspect of ID?
I think that is such a changing field, like there's just always something new coming out. There's always new literature coming out about, whether we can use antibiotics for fewer days, or there's new antibiotics that are coming out. We might have an oral carbapenem sometime in the near future, which is both horrifying and exciting. So I think that's what's kind of so exciting about it. But the other thing is that there's so much you can do, like with ID, there's not just one path. If you like hospital epidemiology, or you like global health, or you want to go do outbreak investigations, there's just so much flexibility for you to really tailor your practice and what you're doing to what your interests are. So but yeah, I just love ID.
So on the other side of the spectrum, just for the students who are interested in ID, what are like some of the dislikes or the frustrating aspect of ID that students should be aware of?
And I'm not sure how specific to ID they are in general. I think there's just some frustrating aspects to medicine, I would say. So, documentation by far, I think, across the board, you talk to anybody in any specialty, it's a blessing and a curse. It's nice to, you document so that way people know what you're doing and what you think. But it takes up a lot of time. You see a lot of patients. It takes a while to kind of document everything. And especially in ID, when, you're kind of putting together so many details and so many aspects of history. So, I think that's one thing you're never really going to get away from unless you go to like another country where there isn't documentation, but for better or for worse. So I think that's one thing. And then I think also just, sometimes not always feeling like you have like enough time in clinic to, to just spend and chat with people. Like I'm a very chatty person. So I just, I like to talk to my patients, and I really enjoy sort of that relational aspect. And, but you have a schedule you have to keep to, and you can't talk to everybody for as long as you want. So I think that's, and that's more of like a personal thing, but in medicine, you're always going to be a little bit under a time crunch unless you're in psychiatry. So
Yeah. Yeah.
but
Agreed on that one. What are some myths about infectious disease or MedPeds that you think are untrue or unfair?
So I think probably the biggest one would be about MedPeds. So everybody, not everybody, but a lot of people will tell you, you have to pick one or the other, you have to pick medicine or you have to pick peds. And that's not entirely true. I know lots of people who actually practice both medicine and pediatrics, both inpatient and outpatient. I know MedPeds hospitalist and I know MedPeds outpatient. So I think if you truly want to practice both, there's opportunities out there. And, so I just say, push aside that negativity and, you figure out what you want to do. But I will say that a lot of people who do MedPeds also kind of realize after spending many, many years that they may kind of like lean towards one or the other. So, while I've enjoyed doing pediatrics, I've always kind of been more of an internal medicine kind of doctor. And I think that through doing my 7 years, I finally come to realize that, and that I still love seeing kids and I still feel comfortable seeing kids, especially, when I do my global health projects. But in my everyday day-to-day life, I don't necessarily have to do both of them for me to feel happy all the time. So, but I think that's probably the biggest myth that I know even in med school, people tell me, well, why do you want to do med peds? Like, you're just gonna have to pick one. And it's not true. If you want to do both, the world's your oyster. You can do both.
Yeah, is that for the most part I've talked to, the extra year is worth it.
Yeah.
The training, and every MedPeds I've known have loved it.
Mm-hmm.
How has infectious disease changed over the years, major points, and then in light of COVID-19? And if you can touch upon what you think the future of not MedPeds, of infectious disease.
Of ID. Well, I mean, ID has definitely changed, and it continues to change over the years in so many respects. So I think one of the biggest changes has been, HIV care. So initially when, HIV, when we discovered it back in the 80s and people were dying of it, we didn't have good medications. The medications we had made people sick, and you kind of just sort of temporized it. And now I have patients that can live full, happy lives. Their medications don't make them feel bad, and they actually can control their disease. And they're really no different than managing like a diabetic patient, anybody with a chronic disease. So I think that's probably been one of the biggest changes. And it still keeps changing. Like, there's new HIV medicines that are coming out every year. And so I think that's probably one of the big changes. Antibiotics are definitely also something that has shifted. As people have more exposure to antibiotics, we've had big problems with antibiotic resistance. And so new medicines have had to be developed, basically to help combat some of those multi-drug resistant bugs. So I think that's been another big change. And then obviously COVID has been a huge change to the field of ID. We've had, I guess we had a smaller pandemic with, the flu back in, I think it was 2009. But we've really never had anything like this in any of our lifetime. Mm-hmm. And so I think that's been super interesting, sort of just to see how, at the beginning, we thought hydroxychloroquine worked, and we thought, all different things worked, and we were good. And then we're like, okay, well, that doesn't really work. And, and so I think it's kind of just been interesting to see firsthand how, our recommendations and our management change in real time based on, actually getting, good evidence-based data to make our decisions on. And so I think, we kind of get used to having all these studies for other infections and other conditions that you never realize what it's like to not have that, and to just kind of have to forge the way and find that data. So I think that's obviously been one of the most recent changes to ID. And where I see it going, I have no idea. I hope we don't have any more novel coronaviruses or novel infections. I think probably the biggest problem we're going to have to deal with is the multi-drug resistant bugs. I think that's just something that is going to get worse over time, and that we may run out of antibiotics to treat certain bugs. So I hope that's not the case. I'm really interested in a lot of stewardship to try to minimize that from happening. But I think that's, going to be the future of ID, is learning how to navigate those waters.
Okay, awesome. Thank you for that. And I mean, as a ER physician, we try to as our best as well to decrease the antibiotic resistance. And sometimes, you can't really.
I appreciate that.
Yeah. I was like, you're resistant to everything. I was like,
yes, that does happen.
Yeah, it's scary. And I tell my patients that it's a very scary thing. I was like, oh my God. I was like, there's not that much that we can do.
Yeah.
Anyhow, thank you for that. So do you work with mid-levels such as NPs and PAs, or have you worked with them? And how do you see their roles changing in the future?
So I work with them pretty much outpatient, like my primary setting in terms of ID. So we have a couple NPs that actually work in our HIV clinic, and the last clinic I worked in for fellowship, that was also the same case. So, and I think it's a good niche, for them, because HIV medicine's kind of broad, but also sort of somewhat narrow. We have really good guidelines. Certainly some patients can be complicated if they have, multi-drug resistant HIV. I think that all the NPs that I've worked at in that capacity, I mean, they've been doing HIV medicine longer than me. And so they're always, full of a wealth of knowledge and experience. In the hospital, I've had like interactions with NPs and PAs that are part of other teams, so they'll, be calling consults for me, but we don't actually have any on our inpatient service because we have fellows and residents and med students. So we kind of have a big crew for our inpatient consults that we haven't really needed to bring on any mid-levels for those services. So.
Okay. And how do you think the job market will be in 5 to 10 years for infectious disease?
I think it will be great. So if there's there's been a couple good things that have come out of the pandemic. I mean, one, people are practicing hygiene practices much better that they always should have been doing during flu and cold season. So I think that's been great. But also, I think people realize the value of having an infectious disease doctor on board, and that we can bring a lot to the table. And like Dr. Fauci, he's like the king of ID that all of us would love to be like someday. But the job market is great for ID. I think your biggest issue is going to just be in figuring out where you want to live and what kind of place you want to be in. But there's plenty of jobs. There's lots of academic positions. There's private practice positions as well. So I don't anticipate there being any issues with graduates getting ID jobs.
Awesome. Thank you. And then I'd like to end with the last questions. If you have like the number one tip or top tips that you have for students who are interested in MedPeds, and then I guess residents who are in MedPeds or interested in infectious disease.
Okay. I think for infectious diseases, if you can get as much exposure, not to the actual diseases, but to the field. I think since I knew I wanted to do ID early on, I really tried to get as many opportunities to work with ID doctors or sort of with ID related topics. So I feel like a lot of times people sort of get involved in things that aren't even related to what they're interested in. I feel like time is money. So if you have time to invest in, something that you're interested in, that's the best experience. So like when I was in med school, I went to Malawi to do my public health field experience. So I was in Malawi for a month and I was able to get funding for that, which my mentor helped plug me in. I did Shigella genomic research. I'm certainly not doing genomic research now, but it was Shigella, it was an infection. So I really got some good face time with a Peds ID guy And then in residency, I went to Zambia, to do like a global health trip. And so I think just, if you know that there's a field that you're interested in or potentially interested in, try to get as many experiences as you can. One, so you can just see what that field is like, and meet people in the field and kind of see what they're doing. But two, just give yourself some good experiences. It'll be great, conversation fodder for interviews. And I think will also just help to, kind of keep moving you forward, towards that direction. So
awesome.
That's probably the best piece of advice I can give, at least for the ID side. For MedPeds, I think if you can work with MedPeds people, I think that's probably the best piece of advice, because then you actually get to see physicians who are, combining both the medicine and peds together, and how that looks, in real life, rather than just doing separate medicine and separate pediatrics. So that would be my advice. So like when I looked for a residency program, I really wanted to be at a place that had a MedPeds clinic, and not every MedPeds program has those. So I think that's important, to expose yourself to that, just so you can see what it's like in real life,
Understood. Okay, awesome. I appreciate all the answers that you've given me, and I'm sure the students also appreciate your advice as well.